for your kind introduction. And thank you for giving me this opportunity to talk about advanced imaging and future innovation in colorectal cancer. So we know very well that colorectal cancer is the third most common cancer worldwide. And we know that it's the second leading cause of cancer-related death. Predominantly affect people aged 50 and above. But what happened in Ireland? In Ireland, the colorectal cancer is the second most common cause for male, the third cause for female, and is the most common cause of cancer death. But we need to have, it is important to have a very good colorectal cancer program screening, because increasing adenoma detection decrease the colorectal cancer and get a better outcome for our patients. And you can see here clearly from this study, then the adenoma detection rate is inversely associated with the risk of colorectal cancer. However, we need to consider that 25% of the lesion, despite we have a very good colorectal cancer screening platform, our lesions are missed. And so this will progress in colorectal cancer. What are the main errors? The first error is, you can see here, you can barely see in endoscopy in white light, the lesion is faint, so we can easily miss it. The second lesion is relatively distant, and so can be missed. Also, sometimes the stool or the movement can make these errors. So, if you can look at another problem, which is quite common, is that the polyps, especially the diminutive polyps, they can be hidden by the folds. And if you can look at this study, this was a simulation study using the 3D CT colonography, revealed that this is important, that 80% of the colonic mucosa is blind spot. So let me give you an example. This is a real-time screening colonoscopy. And you can see here, you can just moving, you can't see really the polyps, any polyps. But then when you go in retroflexion, immediately you see that there is a little polyp just behind, just hidden by the fold. And so this could be missed. This is the problem. So how to improve and what we can do for improving all of this? Definitely the future or the present, and this is all available now in Cork. We have developed, since I arrived, a state-of-art of advanced imaging technology. So we have imaging enhanced endoscopy with a virtual chromendoscopy that can give optical characterization of diminutive polyp. And then we have also ultra-high magnification, ultrastructural endoscope. They can see in real-time histology, confocal laser endomicroscopy, and ultra-high magnification endocytoscope. We can see in real-time histology nuclei, but we can also look at in details if the lesion is in the depth. This guide the treatment in terms of endoscopic resection and organ sparing or surgery. The future, which is not anymore, is the present for colonic neoplasia, is also artificial intelligence for better detection and now also characterization, and the characterization of polyp molecular profile, the endomics, then together in a machine learning model, they can predict also progression and guide the therapy. So from the past to the future, from the white light standard endoscopy, now we can see better with the dichromendoscopy, with the virtual chromendoscopy, with the confocal laser endomicroscopy, and with the endocytoscope. And now also with artificial intelligence, with we are using in the real. How do we color the colon for improved detection rate in the same time to characterize our lesion? What does it mean, characterize our lesion? Characterize means prediction. We can predict in real-time histology. We can say predictive the histology, of course, not 100%, but we can say if it's high grade, low grade, or deep invasion, and for a better treatment. And so we can color and dye in virtual or in high definition. So let's just give you an example. You can see this is, can you see it? So this is patients with high BD. And it's very difficult sometimes in this kind of patients to understand what we are looking for. But if you can just use the dichromy endoscopy, you can see that all the lesions before assessing white light, they are all polyps. So the dichromy endoscopy really can help. But the dichromy endoscopy can help also when you see the colorectal, the lesion, the colonic lesion, and you can characterize, and I can show you in real time now in a short time how it's important to look at the surface, the mucosal architecture for better treatment. So look at this study. Indeed, the chromendoscopy is superior than the white light endoscopy. This was a meta-analysis of a multi-several randomized trial. And it's really clear from this meta-analysis that the narrowband imaging or other platform of virtual chromendoscopy can really help to increase the detection rate of dysplasia. So overcome the limitation of the missing lesion. Then they can progress in cancer. Similar to the other study meta-analysis, you see this also other study, which is the linker color imaging, is another kind of virtual chromendoscopy. Then is I call the brightness, the reddish chromendoscopy. And this is an international parallel randomized study in 11 multi-center. And then you can see clearly the LCI increase the detection rate of the adenoma and also the size rate relation compared with white light endoscopy. And we recommended with the European Society of Gastrointestinal Endoscopy to use both high definition or dye or virtual chromendoscopy for better detection rate of adenoma, and also for using the virtual chromendoscopy for optical characterization of the diminutive polyp, the resected discard, which we are not ready yet. And at the same time, what is important, the photo documentation, and then this needs to be performed by a trained and experienced endoscopist. When we look at the lesion, it's important the characterization. And how do we characterize our lesion during the screening colonoscopy? We use the Paris classification, and we look at first at the morphology. Why is it important? Because the morphology can predict the cancer, the dysplasia in low, high-grade dysplasia, and also deep invasion. But after that, what is important, it's then when you have big lesion, then we call LST granular type, so lateral splenic tumor granular type, and no granular type. This kind of lesion, we use a more sophisticated, I will say, classification. But why we are so meticulous in, say, the homogeneous, nodular mixed, flat elevated, pseudodepressed? Because you can see clearly from here, then based on the morphology, the risk of cancer of the deep invasion is increased. So clearly, the no granular type, it's a lesion that should be assessed very careful because it can be a cancer. And so it's much better to do an endoscopic submucosal dissection. Then I will talk you now briefly about what is the innovation of resection or surgery. Another things we use when we do endoscopy is the characterization of pit pattern, the mucosal. The Kudo pit pattern is quite, used in the daily practice. And you can see from here by using dichrome endoscopy, this is a crescent violet, but you can use also indigo carmine, or you can use also metal and blue. Then you can see in details what is the pattern, the pit. They can be roundish, which is normal, can be tubular, which is low-grade dysplasia, can be villous, and or can be disrupted, which clearly is a cancer. This help to define and characterize and make the journey of our lesion. So other classification they can be, now we have developed with the virtual chromendoscopy, then I use regularly in my report by, the virtual chromendoscopy is looking at the color, the vessels, and the surface. This helps us just to define it's an hyperplastic polyp, is an adenoma, it is deep submucosal invasive cancer. So the virtual chromendoscopy is crucial to be used in the daily practice. And if we have magnification scope, which now is common, it's available also in Cork, we can use it with the magnification. We can look at in details the vessel pattern, the surface pattern, and we use this genetic classification, then can predict if it's low-grade or high-grade dysplasia of cancer. Let me give you an example. So this is my lesion. I'm using the detection, so I detect this lesion, then I use a virtual chromendoscopy, I use the Paris classification, and so it's to A to C because there is the depression, there is a Kudopit pattern, so I will look at the pit of the mucosal, and then I will look at it with magnification, which can help. This is a type 3, so it means then the lesion has deep invasion. So this means then this lesion can be removed with EMR, endoscopic mucosal resection, but should be removed with endoscopic submucosal dissection. Let me give you more an example. So these are two lesions, both different lesions, but they are LST, so lateral splitting tumor with nodular mixed type, both of them. So what you look at is important when you do colonoscopy, use virtual chromendoscopy, because give you, and also dichromendoscopy. The dichromendoscopy at the end with indigo carmine or methylene blue can help you definitely to define what is your margins of the action of the lesion, important for resection. In the same time is important for the define better your pit pattern. So this is what I do in my daily practice when I see the polyp. So I use the best scope I have, then meticulously I go to Paris classification, Kudopit pattern, and genetic classification. What is the endocytoscope available here? The endocytoscope is an ultra-high magnification scope. So you can see here, this is a polyp. So you use a virtual chromendoscopy, and then you magnify 520-fold of magnification, and you can see it at cellular level. So you use methylene blue, or you can use crystal violet. It's not very common here, but we use mainly methylene blue. Then you can define what is the nuclei. And so you can define the nuclei, you can define also the crypt architecture, and then also the vessels. And we use this classification. The classification, then look at the lumen, and they look at the lumen of the crypts and also the nuclei. And based on this, we decide in predict if the lesion is an adenoma or if it is a cancer. And what about confocal endomicroscopy? Available also here. The confocal is, can see in real time cellular, subcellular levels using fluorescein agents. You can see the vessels, you can see the crypt architecture, and so this is the normal rectal mucosa. It's a laser and has 1,000-fold magnification. You can see in real-time histology. So you see the adenoma, how it looks like, and this is the cancer. You can see this disruption of the crypts with the leakage of the fluorescein, and so this can help in real time. But the eye is not the future. The eye is the present in colorectal cancer. These are all the eye. So what is CAD-E, CAD-X? So CAD-E is for detection, and CAD-X is for characterization. And these are all the approval AI now available. But what is the AI answering to? quality, standardization. We failed despite all the training. And AI increased detection of neoplasia. You can see here from this meta-analysis. And AI is easy and fast for CAD, for detection, and also for characterization. Look at it, tell you if it's an adenoma or not. But the CAD also is important in the study, has an accuracy of 84%, so which is important. Also CAD, we have also EndoBrain. EndoBrain AI is available in Japan. So you can see real time when you are just withdrawn in your colorectal screening program, the eye is spotting you the polyps. And this was a cancer. It was a T1 invasive cancer. So the eye can also help in this. And the new EndoBrain X will tell you about combination, about detection and characterization simultaneously, which is important for making immediately decision. And more sophisticated, it's the EndoBrain. It's just a real-time histology by using endocytoscope. Then you can see this is the polyp. You use the endocytoscope with magnification 520-fold, and this was a well-differentiated adenocarcinoma T1B with invasion, lymphovascular invasion. But what is the limitation of the eye? Is the false positive. So you can see when you have a scar, when there is advanced neoplasia, when there is, very difficult for SSL with dysplasia. So this is still the limitation of the eye. And what is the future of the eye? The eye is also combining the endohistomics. So this means you can see this what is the future of the horizon, try to predict what is the progression by using, of course, omics, spatial multi-omics and gene profile markers, and all in the machine learning predictive module to predict outcome and organ sparing. But how do we treat? But of course, the challenges of AI are many. So, and I think my colleague Andrew will talk about the inception, the development, the validation, the monitoring. We need guidelines, we need standardization this, and especially cybersecurity, which is the big issue at the moment. But how do we treat the neoplasia? So we can treat the neoplasia, or we can do really organ sparing, or we send the patients for surgery. So let's give you just an example. How do we manage our polyps? If we have no pedunculated or pedunculated lesion based on the morphology of Paris, if the lesion is more than 10 millimeters and the lesion is no invasive lesion, we just use endoscopic mucosal resection. They can be en bloc or can be in piecemeal resection. If we have a suspected submucosal invasion and he's just SM1, so means not deep, we use a endoscopic submucosal dissection. So this is the mucosal resection. This is en bloc, but we can do also in piecemeal fashion when it's a big lesion, doesn't have any deep invasion. It's very easy. What is the advantages? It's relatively simple to perform. Device is easy, has a long track record has been successful. But what is the disadvantages? No accurate histology diagnosis and a lot of recurrence. And so this, they increase the recurrence is important, because then it's very difficult after recurrence for fibrosis to get back in the eye perforation rate. So for this reason, now we have there are another kind of technique, which is the endoscopic submucosal dissection, going a little bit, deep. You can see this lesion. This lesion is depressed in the center. It's this SM1 invasion. You don't want to do EMR in these patients, but you will do an endoscopic submucosal dissection. And the submucosal dissection has been developed in Japan, initially for gastric cancer, but now they use this knife, which I will use, and overcome the limitation of conventional EMR. However, it requires a very expert and skilled endoscopist because the risk of perforation is very high. So let's see what are the advantages. The advantages is curative resection because it's en bloc, accurate histology assessment, low recurrence rate. But the technical demanding requires advanced endoscopic skills, longer procedure, high rate of perforation in not experts' hands, and hospital admission. We use this kind of knife. There are many now, and of course, you need to use all this very, advanced equipment. So it's crucial to use all these fancy things: the cap, the CO2, the right scope, and the right knife. You see here, we go deep. So we go in submucosal dissection, and with the knife, and then we have a completely en bloc resection. You can see here, and then you can have the completely piece out, then can be with an accurate histology rate. So let me give you an example. So this is what happened during the ESD. So we inject, and then with the knife, we start just, to dissect. In dissection, we go, easily dissection. Of course, you can have fibrosis, you can have bleeding, and you can have perforation. So this is what the European Society of Gastrointestinal Endoscopy guidelines recommend. So, of course, you have a lesion in the colon. You need to assess with high definition virtual endoscopy, Paris, the mucosal vascular pattern. And if this is suspicious of SM1, some mucosal invasion, you should do ESD as a first option. If there is no invasion, you use, EMR. But in high-grade dysplasia and in the rectum, you should use the en bloc EMR ESD resection. The challenging bleeding, the challenging is the fibrosis, the challenging is the perforation. This is interesting. I will show you now the comparison, between the West and between Japan and between America and also Europe. So West and East. So you can see here, of course, the Japanese, they have very low rate of perforation, and the curative resection and block resection, 97%. And they of course, you can see the intra-procedure bleeding or the complication are very low. But what happened and so it's becoming more common. What happened in terms of long-term outcome is safe to do in terms what is the outcome in terms of 5 years disease-specific survival rates is 99.6%. So it's safe to do. In the same time, what happened in the Western world? It's more difficult, despite now there are many centers they have adopted. It's a longer procedure, so, it's not paid off, increased risk of perforation comparing to EMR, lack of adequate reimbursement, and required time skills. But if you can see the first, large prospective multicenter study, you can see then also the Western country, they are becoming samurai. And so with hospital length is just less than 2 days, lesion recurrence is 5.8, and the bleeding and perforation is 2.3 and 2.9. And so this is supporting also the implementation of endoscopic submucosal dissection for treatment of mini-invasive surgery for the West. And also this recently clinical outcome of no curative endoscopic submucosal dissection around the world support the implementation of endoscopic submucosal dissection for treatment strategy and organ sparing. And this is our first ESD. I'm so proud. So we did also an ESD in MUH Cork in October 2023 with my colleague friend from Japan. And we have also kicked off with the ESD ends hands-on workshop in a search center in UCC Cork with the animal model. And so just what is the message to take home? The advanced technology and the optical enhancement are crucial during the colonoscopy because they can characterize, assess colonic lesion, guiding treatment, so increase detection rate, reduce colon cancer, characterize, guide therapy, innovation with endocytoscope and confocal laser endomicroscopy. Definitely it's here, and it's the future of the horizon. The endoscopic submucosal dissection, it's a technical difficult, but in expert hands can really change the game with organ sparing. In the future, the artificial intelligence is not the future, the present of the artificial intelligence in detection, lesson characterization definitely will help with therapeutic intervention and organ sparing. Thank you very much. And with this, I would like to introduce my colleague, Professor Andrew Hope. Then he will talk about the artificial intelligence.
Thank
Andrew?
You, Dr. Marietta. I will, give me 1 second to get the share working. And hopefully you guys should be able to see the slides now. I was asked to quickly go through some, I'd say, kind of nitty-gritty details of AI. And I think the most important one that I wanted to talk about is actually the role of the clinic in helping AI to work, and also to kind of the opposite, which is helping to understand how AI should affect the clinic. And so some disclosures, I do have funding for this as well as unrelated to this talk. But I think this cartoon kind of illustrates a lot of AI talks. On one hand, there are several positive sides. On the other hand, there are several malignant aspects. In conclusion, this is AI is here to stay. This is every talk ever. I'm an expert. Clap, clap, clap. So this is the summary that I'm trying to avoid. I'm really trying to give you some actually actionable information about AI that hopefully will help you affect the way you're going to move forward in practice. So when we're implementing AI in the clinic, what do we really need? We need two things. We need evidence and we need infrastructure. And I'm going to talk a little bit about the questions that underlie these two aspects. One is the evidence. What sort of evidence? What is enough evidence? How do we get the evidence? But also, I'm going to mention some of the issues of the infrastructure, which is, where do we actually put these new models in the clinical environment? How do we access the relevant clinical data? And how do we do it in a clinically relevant time frame? But probably most importantly is, how do you inform the medical team about the results, and how do they action something as a result of those changes? So there's a loop here that you'll kind of see, is that without the infrastructure, it's hard to get evidence, and without the evidence, it's hard to buy infrastructure. So I think we really have to think about them as a compact group. But for those of you who are unfamiliar with AI, I know it was mentioned in the last talk, but AI is really just a classification of machine tools that are designed to mimic humans. Some of it can be hard-coded, flexible, inflexible. It can learn from data. The parts that are becoming more and more prevalent are the parts that are the machine learning, which is the learning from data automatically. Even though the more traditional machine learning was handcrafted, you can actually generate lots of data and then have, with deep learning, have the tools learn from the data itself without really any significant human interaction. And I think this is why we are starting to see the explosion of AI within medical fields, is because people have a lot of data in some situations, and they're starting to apply these tools broadly. They do have some issues in that they require crunch, which is to say computing, and they also require a little bit of kind of understanding of the tools, and that's what I'm hoping to help provide some. So that's been your brief intro, i.e. machine learning for me. So many of us have heard about AI in the context of games, and I think the most traditional thing that we all got exposed to was this AI winning or beating both chess masters and, more recently, Go masters, who previously were thought to be untouchable. And it really was these deep learning models that learned this game. The difference between game AI and real world AI is that in many cases, medical AI may not see the entire picture, whereas a game can always see the entire board. We may be thinking about kind of malignancy in one context, and if we're modeling overall survival, oftentimes there's other things that will affect overall survival that we're not including in the data set that the AI can look at. things like cardiac disease or genetics or the socioeconomic status that drives a lot of these underlying conditions in terms of smoking and alcohol. But it could also be just a speeding Tesla on the highway could take you out, right? So any of these things can affect overall survival. And so if the AI can't see the data related to these, it's very hard for it to make decisions or help you do predictions that will be relevant for the endpoint of overall survival. So why in radiation oncology do I care about AI so much? I mean, I think radiation oncology is a relatively unique specialty in that we live almost entirely in the imaging and digital domains because radiation oncology is a local therapy that's planned on a computer. It's delivered by a robot that's driven by that same computerized plan, and our follow-up is in many cases an imaging test. So we have kind of an end-to-end imaging, unique digital environment. The only thing that really doesn't get in there is, the physical examination or maybe some of the clinician's notes, but even that is now starting to be digitized. And so as a result, AI has the potential to be integrated into a standard radiation oncology workflow very straightforwardly, as it does in many other specialties. But I think, as in surgical specialties or other interventional specialties, there's a lot of subtleties that have to do with the way the surgery is done or the technique of the surgery that makes it hard to digitize. I'm hoping that will change, but I think radiation oncology has a leg up right now in terms of the amount of digital data we have available. And as a result, there's a whole bunch of tasks in radiation oncology that could benefit from AI. In the general automation category, things like review of medical records, which is something that happens in all fields, is relevant and it saves time. But within the radiation oncology planning and delivery, we actually routinely segment patients and contour them, and that requires lots of time. That's easily automatable. The dose calculation, also easily automatable, which is the computerized calculation of where the radiation should go. And there's also decisions that we make on a regular basis to deliver the plan on a given day or not. And again, those can be automated relatively straightforwardly. But I think the things that people think about AI more for is the prognostication. And that's where we're trying to predict what's going to happen to patients based on the presence or absence of underlying conditions. And I think this is where it gets very interesting because this is where I think a lot of tools are going to be developed and deployed that will allow us to ask these sorts of questions in the future. But I think it's important that you understand that AI isn't really complicated. In the end, it's a really simple digital system that takes an input and gives you an output. And in the middle, there's this model that makes that transformation from input to output. And in that way, it resembles a laboratory test or a radiology study or even a clinical decision tool in the sense that we do these things all the time. We have blood tests that we understand. If we take a blood sample, we give it to the lab and we get a result. That's what we should really be thinking of AI as a process, a test that we can run on a patient that will do things. But again, we need evidence and we need some understanding of how that can work. So how do we assess the efficacy of AI? How do we develop that evidence? I think this paper is probably my favorite paper. It's a description of actually a radiology architecture or thinking process whereby they divided the ways that radiology tests were effective into different levels. So at level one, how good is the actual test at making a picture? So the resolution of line pairs or the grayscale range or the sharpness of the image. Level two includes things like diagnostic accuracy. Does this thing detect pneumonias or can it detect a bone being broken? And then if it does, can you calibrate that with some accuracy or some percentage of likelihood of it catching the result? So, true positives, false positives, those sorts of things. But more importantly, beyond those levels is, does it change the way the clinician thinks about the problem? That's the level three. And as a result of that change in thinking, does it change the sorts of treatments that we give patients? Does it adjust the sorts of treatment that we would choose? And as a result of that, do we see patients getting better care? Do they live longer? Do they have better outcomes? Do they have, less toxicity? In the end, we'll probably want to be testing AI at the societal level to say, if we deploy AI throughout the hospitals in a given jurisdiction, do we save money and do patients do better? But these levels are really hard. And so AI has the exact same problems. At level one, we want to make sure we're selecting the right features. At level two, we want to make sure we're getting the right sensitivity and specificity. Above that, we start having to ask about patient outcomes. So trials that involve AI need to be done to prove that we're affecting these sorts of things. And then eventually we'll be able to do kind of randomized tests of, if you do or don't have the AI, is the result of the procedure better? And, I think we're going to be a long ways off from societal impact because AI is not pervasive yet, but it will be. And we will need to do these sorts of tests to prove that it's worthwhile. But I think I've coded these in a way that hopefully helps people understand that there's kind of a couple layers that we need to worry about. Below this squiggly line, these are things that we can do retrospectively with big piles of data from lots of hospitals. But above the squiggly line, it's really a trial thing. And I'm going to show you quickly one trial that I really like, and that it's a randomized trial because randomized trials are kind of the standard, but there aren't very many of them in AI yet. This is the example that I like to use. It's a HYPE trial, which is a fun name for an AI trial, but basically they used an anesthesia bot that basically monitored the anesthesia doctors and watched them go through the procedure. And to predict what happens to the patient, they built a model that would watch all the data in the machine and try to basically flash a red light anytime the machine thought that something bad was going to happen in 5 minutes, 10 minutes, or 15 minutes from the current time. So it gave a heads up to the anesthesia doctor that something bad could happen. So what happened when they turned this thing on versus not having the light flash? The AI arm, when it warned people, gave less hypotension, less chance of hypotension, faster reaction by the doctors to events, and less serious adverse events. This was a huge boon for the people in that OR because the AI basically told the doctor that something bad was going to happen before it did. And that's really, it used a previously validated tool that had those early levels of sensitivity and specificity proven. It compared it to the standard of care, which was not warning the doctor. And then it had the same availability. It basically was just turning on the warning light. So it's kind of silent versus active. And the endpoints that they addressed were ones that really mattered. These are patient outcomes. And it really is that Fryback and Thornberry level 4 and 5 stuff that we care about. So back to the tasks in radiation oncology, there's a whole bunch of them I mentioned. I'm just going to touch on one. I mentioned that contouring is kind of solved. And we and many other people have published on the ability to generate AI models that replicate the ability of a human to draw a circle on a CT scan around a given structure. It's relatively straightforward now to do that, but we still have to generate things that are clinically acceptable. So if we have a brainstem and most clinicians agree that it's usable, great. But if they decide that it's not usable, that model needs to be improved. And so there's lots and lots of work being done right now to basically remove this as a task from my job and hopefully move it into a computer space to save me some time. That's an automation task that I think will be pretty pervasive. But I think it's important to classify AI for clinical deployment. There's kind of low risk stuff, which is, like I just mentioned, a contour assistant, where it's gated by the clinical staff. It's assistive. It's not intended to affect clinical decisions like auto-segmentation. And it's something that we are always going to look at after it's done to make sure it's working the way it's supposed to. But there's other types of AI that may be more dangerous. So things like things that affect clinical decisions, but not independently. Clinical decision support where it may influence the clinician and in some cases may influence the clinician negatively. I really enjoyed in the last talk the discussion of the endoscopy tools that are being deployed where they highlight lesions. The question that I was thinking about during that talk was whether or not they looked at the proportion of times that the clinicians got a little less focused on areas that the AI wasn't as good as detecting. So I think these sorts of things have a medium risk where they can affect the clinician in a way that may not be completely predictable. But I think the highest risk ones are the unsupervised AI within the clinical environment where automated systems are designed to trigger without clinical oversight. And I've put the relevant robots below here, Wall-E versus C-3PO versus, the Terminator. I think these are the ones we want to think about as potentially more dangerous on the high risk end. So let me give you an example of one of the projects that we've implemented internally to our center using a low risk kind of approach. This was presented earlier this year at one of our national meetings, but it's basically a prospective assessment of a screening tool for a specific lung disease. I treat lung cancers, and one of the problems in lung cancer is the presence of interstitial lung disease as a background condition. It's a comorbidity that is both increased in prevalence in ILD in lung cancer cohorts, but it also seems to cause lung cancer. So if you have ILD, you're more likely to get lung cancer. The issue is that if you have ILD, you're also more at risk for complications of radiotherapy and also other treatment modalities. But for radiation, it actually can increase the risk of death or pneumonitis by a substantial margin, either doubling or even tripling the risk of complications. But the problem is that in many cases, the clinical symptoms or diagnostic imaging that have been done prior to our radiotherapy decision to treat may not have detected that. And so there's a chance that patients may slip through the cracks with this diagnosis and come to be treated with radiation, and they may have a problem. So what we've decided to do is to basically look at this kind of after we decide to treat them. There's one more thing we do, which I mentioned before, which is I draw on this CT scan where I'm going to treat, and then we calculate the dose. But the important thing to recognize is that this is an image, and this image could be interrogated by an AI to determine if there's a presence or likelihood of having this background condition of ILD. And so that's what we did. We had a grant that we put together that basically said, we're going to try to identify patients with ILD based on only their treatment planning scan. And so we built an AI that basically took the treatment planning scans, put it through a big black box that we call this miracle system, and put out a score. And what happens under the hood is effectively we contour the lungs, and then we take that tissue that we've contoured as lung, and then we classify it as high or low likelihood. There's some details about the actual tools, but realistically, these are very normal AI tools that can be applied to these sorts of images. And what we've done is just kind of link them together to do this task. So what we need, though, is data. And so initially, we started with a whole bunch of diagnostic data, nearly 4,500 diagnostic CTs, of which about 1,000 or so had this background condition. And we trained the AI to look, and then we had it kind of classify on a bunch of our planning CTs. Unfortunately, that didn't work very well. And as a result, we had to go ahead and retrain the model on these planning CTs and then test it on further data to prove that it worked. And this is the result that we get. This is an ROC AUC curve that gives us a predictive characteristic, in this case, the AUC, that tells us that, we get a pretty good chance of identifying patients. We have to do one more step, though, because as I talked about in the very beginning, this is kind of a test. So I need to call this test either positive or negative. And so I've decided to basically threshold this test right here. And this is the value we're going to use, which gives us about a 65 to 75% sensitivity. But that's at the cost of about a 15 or 20% false positive rate, which means this thing's going to be hyper paranoid about ILD. And so it's going to raise a red flag quite often, but it's not going to be able to catch all of the patients. And so it's a limitation of the tool as it is currently. We then said, okay, let's test this prospectively. So once we've determined this, we have this new model, and then we decided to deploy it in our environment. We have some infrastructure that allows us to do that, and we have ethics oversight where we talked to our ethics team and said, hey, how do we do this safely? How do we do this ethically? We put it into a prospective monitoring system where every patient that was going to be planned for radiation had this AI look at their scan briefly overnight and then basically recorded the result. And so we had two planned implementation phases, just like in the HYPE trial. The initial phase was going to be silent, where it just looked at the data, didn't send any notifications until we knew it was working or not in the environment. And then once we were going to turn it on if it worked. And every patient was looked at by a diagnostic radiologist to confirm that they either did or did not have that diagnosis. So for 180 patients, we looked at this prospectively and showed that within that population, the AI flagged about 15% of them, and it caught a total of 28 patients that it thought were suspicious. As it turned out, it caught 50% of the unknown ILD cases that were in our population. And we were really excited by this because these were patients that would have gone on to be treated with radiation, not having known that they had this background condition. And so once we saw this result, we said, okay, let's turn it on. And this performance was very similar to what we expected. So this was the kind of simple, the warning light in the OR equivalent. This is an email that gets sent every night in the event that your patient has this high risk identified by the AI. There's no changes to the AI model. The only difference is we turned this thing on. And then we collected some feedback about whether or not this survey helped people understand whether or not the AI was doing what it was supposed to do. And so we then collected another 250 or so patients prospectively with this live warning people. And again, it flagged about 15% of patients out of the 254. And then of those, there were 13 ILD patients identified in the population, and it caught 3 out of the 7 unknown ones. There was always some patients with ILD that we're treating, but not very many. But it caught, again, 50% of the unknown cases, which for us was a big win. These are, again, patients that would have snuck through the system and been treated if we hadn't identified them with this system. Again, reasonable performance, And when we combine all of the prospective data for this patient population, we can show that we catch about, roughly half of the patients that are unknown. And this isn't perfect, but it's better than what we had before, which was, these patients going ahead to get treated and potentially having complications that we would not have expected because of this background condition. So when we look at different subsets, this works in patients who are getting treated for small lung cancers, for big lung cancers, and even for palliative patients. And we think this is an important tool that may help us at our institution. And the overall performance here of 0.76 is very similar to the validation study that we did that proved that it should perform similarly in our environment to what it did originally. So what we did is we think we've identified a new AI way to diagnose ILD in the process of treating someone with radiation, where we just scan their treatment planning image and make sure that it's actually safe to treat them. And we validated this prospectively within our institution, and we're hoping to do that same thing at other institutions around the world right now. But I think what's nice here is that this demonstrates kind of end-to-end how you would go through the process of designing and implementing an AI tool within a clinic. And it relies on really heavy interdisciplinary teamwork to both, computer science and radiology and all of the radiation oncology team. But it also is a clinically acceptable workflow. It's integrated into our treatment planning process, and could be directly integrated into other planning systems. And we're hoping, as I mentioned, to evaluate this in other centers to see if it works. But this is currently live. It's screening every patient who's getting thoracic radiation at our center all the time. And so I think this brings us back to the issue, which is we really should, when we're thinking about implementing AI in the clinic, we need to focus on infrastructure because the models have to live somewhere. And in this case, we live in Mira, but they have to have access to the data stream. And again, in our environment, Mira provides that linkage to Mosaic and PACS and Epic and all the other computer systems that work in our environment. We can access them on the back end. And it has to produce a visible, clinically relevant result. The email is kind of a kind of gross way to do it, but there are, logical ways to inject results into electronic medical records or potentially in other ways. But I think the point here is that the model that the AI kind of creates the result has to be clinically visible. It has to be actionable. It has to be timely. And that means that we also have to know whether or not it's working, and we have to monitor the model usage. And so we have a system that actually tracks how often this is running, what the proportion of positives is, how frequently it's being triggered, and we can monitor the performance of this over time to see if it's still working. And we can even track to see if the model values are staying within a certain prescribed range. So this is the sort of system that you need to have if you're going to be implementing AI broadly through your institution, is you have to be able to understand not only where it links in, but how it's going to evolve and change over time. So I think everyone should focus on infrastructure. And that's one of the reasons I think I was asked to come and talk to you guys, is that you really need to develop a strong institutional infrastructure for AI to enable rapid model deployment. The more access and the more linkages you have, the more easy it is to develop new AI tools because you have access to the underlying data that allows you to train those tools. But it's really simple once you have that to just turn them on in the background and let them monitor the data in a silent mode. And then once you start developing these tools and continuously can develop these tools, that means those infrastructure investments mean more support, more grants, and more chances to improve patient care. Because as I said, the linkage between infrastructure and evidence is actually quite direct. So I'd be happy to take questions on this, and I'm sure my colleague Marietta would be happy to take questions on any of her stuff. I know I went pretty quickly, but I wanted to make sure we had time for some questions as well. So thank you very much.
So thank you to both of you for two very complimentary and great talks looking at future and really the future that is already here. So both speakers had agreed to the talks being recorded, which has been, and the Q&A session will also be recorded. You can push the question to the chat box, or you can ask verbally by unmuting your microphone. Maybe I will kick off while you are pushing your questions. And a very general question, maybe start with Andrew, then move to Marietta with the same question. So in the spectrum of what you've described, Andrew, and where exactly are we between AI being a decision support tool and a decision driver? Where exactly are we in that spectrum?
Yeah, I think right now we're very much even pre-decision support. And I say that because I think it's very unclear that a lot of the tools that have been developed technologically have been tested in a rigorous way prospectively to determine how they're interfacing with the clinical environment. Because as I mentioned, there can be off-target effects from AI, which can include changes in underlying clinician skill, their comfort level with the tools, or even their ability to use the tools safely in the clinical environment. And I think it's important to recognize that those changes will happen because they're time efficient in many ways. But I think as the comfort level with those tools emerges, I think we'll be able to determine how quickly things will we'll move into the Terminator phase where things are doing things on their own. I don't think it'll be soon, but I think it will be a part of clinical practice in the next 5 to 10 years very easily in every specialty.
That's great. And Marietta, what are your views on it?
I think for us, it's just decision at the moment. If you think, we have available AI, then are currently used in clinical practice for detection. Still, I think we are, in the pre-characterization for legal issue and also for the difficulties of the eye to differentiate between sessile lesion and other lesions. So I think we are there for detection, but still work for characterization and guiding, driving therapy.
Thank you very much. Roisin Connolly, Roisin is the professor and leads cancer research. Roisin, do you have a perspective on the very pertinent question about infrastructure that has to support AI with relevance to Ireland and especially UCC, Roisin?
So that was actually one of the questions I was going to ask Andrew, was his thoughts in general on funding of this. As yourself and Marietta both mentioned, this is coming. So one question I had was around how we optimally train our trainees so that they can see this as sort of part of the norm in the future. And then the other question was around funding. So I suppose we have two aspects to funding. One is the clinical infrastructure and how our hospitals are actually set up. And then the other is funding for the research on top of that, which may not require a huge amount of support, in that it's not new drugs, it's not, it's more staff to be thinking about these and getting the protocols written, etc. So I think we're delighted that Aisling Barry has joined us in Cork, who has an interest in this area and the optimal use of data and all of the information that we have around patients. So I think this is a space that we should work together on in terms of ensuring that our infrastructure is maximized. And I think that'll be a mixture of, first of all, deciding what we need and then going to both national sources, our CEO of our hospital to work towards better infrastructure, but then having teams maybe working on grant applications to bring trials to Cork, as Andrew has referenced, which were very exciting. So maybe, Andrew, we can go back to the training side of things and what maybe Princess Margaret is doing in that space across disciplines, or what do you think would be the optimal, if you have thoughts on that?
It's a tricky question because I think there is a certain degree of familiarity with the concepts, and that's one of the reasons I gave the talk I gave, is that I really wanted people to understand there is a relatively simple way to think about AI, but the underlying tools end up having to be a multidisciplinary thing where you have to collaborate very carefully with your computer scientists and data scientists to understand the limitations and the abilities of these tools. And those probably require some specialty training. And so we at the University of Toronto and Michener have actually an entire AI stream now where we get certificates for different levels of different types of clinicians that in some cases allows them to develop basic coding skills so they can really implement their own tools on data streams that they have available. But I think the bigger question is going to be how we do that at scale, because I think there aren't going to be a requirement for everyone to understand the really nitty-gritty black box stuff. I think most people need to understand how to use them. and what limitations they have. But I think the limitations part is the biggest one, because if people take these tools and use them in places that they're not designed for, they can expose problems that may not be fixable downstream. It's kind of like, you know, using a hammer on your car. It works in some situations, but you're more likely to break things than you are in other contexts by using the right tool for the right job.
So I was, you know, very happy that you mentioned a lot about what you did in terms of sensitivity, specificity, and whether these tools are actually changing practice, impacting patient care. And so you know, as many of us do on the clinical trial side, how a biomarker or tool has to be very carefully taken from the very beginning all the way to clinical utility. So it's the same for AI as it is for other tools.
I don't know that
it should
is
be
in all hands, but it should be.
Yeah, it's very exciting. And Marietta, your
So
talk was wonderful.
Very quick question to Marietta. So you showed how refined and accurate one has to be in doing, say, endoscopic submucosal dissection and the risk of perforation. Do you think AI-driven robotics is going to take over to a great extent, or that is dream?
I think it's taking over. I don't know for sure. You know, I will say not, but definitely the robotic. There is at the horizon a new device, ESD device in the hands of the endoscopist, driven by a robot. So by a robotic. So yeah, I think this is because to time consuming, reduce the time cost and also complication. But there are a lot of companies, they are working on this to improve the existing devices and in a robotic way.
Okay, thank you. And a last quick question and a quick answer from Andrew. It's the same kind of skepticism we had when we had our first iPhone 6 in our hands. I think a lot of patients already start to articulate that it kind of all seems like a bit of a black box. How do I trust what the AI is saying it is going to do to me? So that's more of a kind of not only an ethics question, but almost a cultural question. So do you have any quick answer to that, Andrew?
Yeah, no, and I think that you've hit the nail right on the head. We have a bioethics team that we put together that we're actually doing work on this space, looking at both patient and clinician trust issues within the context of AI as it's deployed within our institution. And one of the things we've identified is that there are going to be a pretty broad spectrum of patients' opinions regarding whether or not they want to have AI involved in their care or not. And so I think the important thing to recognize for us is that if we consider AI as a test, you know, the same way we do a blood test or a CT scan, as long as the clinician is gating that result, I think AI can be used very safely, so long as we understand the limitations and the tool itself. Because patients just trust the fact that blood tests work, they trust the fact that radiology tests work, they trust the fact that surgeons and everyone else can do their job. And I think that maintaining that clinician patient trust is integral if we're going to implement AI behind the scenes to help us all be more efficient and do a better job with patient care.
So with that, I'll thank both our speakers, and that was a terrific pair of talking going on. I must thank Professor Roisin Connolly for hosting this UCC cancer seminar series, which is hugely valuable and brings experts from all corners of the world. So that is superb. And also for the audience to join and participate and have a recording of it that can be used in future. And all that is left is wish you all a very Merry Christmas and then eventually a great Happy New Year. So thank you very much for joining today. Bye-bye.
Thank you very much. Bye.